Hello, my name is Robert Giuliano. I'm the editor of CardioSource's Anticoagulation community, and I'm here in Dallas, Texas at the American Heart Association with Dr. Stephen Kimmel talking about some exciting results from the COAG trial. Dr. Kimmel is from the University of Pennsylvania. What can you tell us about this very interesting trial? What led you along this path to ask this interesting question?
Well, there's been a lot of interest in the use of pharmacogenetics for drug dosing and drug selection, and warfarin has served as a real model for that. And there's some data that suggests that using genetics for initial dosing of warfarin might improve therapy, but most of that comes from observational studies, and the randomized trials that have been done have been very small and unblinded and not definitive.
Well, congratulations on pulling off such a challenging trial. Can you tell us a little bit about the study design, which I think is very important to understand the results?
So it was a randomized double-blind trial stratified by race of 1,015 patients, and it had a couple of key design elements. One was, as I said, we stratified by African American versus non-African American because we know that the dosing algorithms work differently in those populations. We also blinded to warfarin dosing and to whether patients were having their genotype used or not to maintain the blinding both during the initiation and during the follow-up period. And then we also powered the study to look at the two groups, one the primary group and the second was the group that had the biggest dose difference in whom we anticipated we'd see some benefit. Great.
And could you share with us what the primary endpoints showed?
So the primary endpoint, which was the percentage of time in therapeutic INR range at 28 days over the first month, showed no difference between the pharmacogenetic versus the clinical arm. And the pharmacogenetic arm used both genetic information as well as clinical information. And the clinical arm, of course, used only the clinical information. So it showed no benefit either overall or in the primary co-primary analysis of those patients who had a predicted dose difference of more than 1 milligram apart between the two groups.
I see. And you had some pretty interesting secondary findings coming from this trial.
Yes. So as I mentioned, we enrolled a large number of African Americans, and this was actually the largest trial to date. Up until now, all of the trials of pharmacogenetics versus clinical dosing combined enrolled 3 African Americans. We had 275 in our trial, and we found that the dosing strategies differed by race. In the non-African American group, there was no significant effect of the pharmacogenetic dosing, but in the African American population, in fact, the clinical arm, clinical dosing arm did better than the pharmacogenetic arm.
Great. Well, congratulations on some very interesting findings. Where are you going next with this?
Well, there's a lot more analyses to be done, trying to explore some of the reasons for the findings that we have, and there are other trials that are coming out soon that are answering somewhat different questions, and our hope is perhaps to do some additional meta-analyses with those trials, perhaps looking at clinical endpoints like bleeding and thromboembolism.
Great. Well, thank you very much for joining us today on the Anticoagulation Community for CardioSource.